All right, so this is the final part of the metabolism regulatory lecture for patho. For this one, we are going to focus on diabetes. So just a brief reminder on nutrients and how they're metabolized and stored. Glucose, fatty acids, and other substances are what fuel our bodies, and it's the liver that controls the storage and the mobilization of the different fuel supplies. Unlike other parts of the body, the brain and the nervous system rely almost solely on glucose as a fuel source. So this is why when someone has severe and prolonged hypoglycemia, it actually can lead to brain death. So the body tissues obtain glucose from the blood. When you're looking at normal fasting blood glucose levels, they should be between 70 to 99 for someone who is not diabetic. After a meal, the blood glucose levels are going to rise, and that rise results in an increase in insulin release. It is released from the beta cells, and the beta cells are from the pancreas, and the islets of Langerhans. We'll talk more about that in a minute. And then this insulin release is what's going to allow glucose to be transported to body cells. So about 2/3 of the glucose after a meal is stored in the liver or skeletal muscles as glycogen. And if there's already glucose saturation, then the glucose is going to be converted to fatty acid by the liver and stored as triglycerides in the fat cells or the adipose tissue. So glycogen, as I said, is the stored form of glucose. And when the blood glucose levels fall, the liver converts the glycogen back to glucose. And the process of the liver converting this is called glycogenolysis. For gluconeogenesis, this is the process of the liver synthesizing glucose from amino acids, glycerol, and lactic acid. And then that glucose that is made is either put back into circulation or it is stored as glycogen for later. Moving on to fat. Fat is the most sufficient form of fuel storage. About 40% of calories obtained in the American diet are from fats. The mobilization of the fatty acids to use as energy is done by enzymes, so the lipases. These lipases are going to break triglycerides into the glycerol and the fatty acid components. So glycerol can be used along with glucose, or the glycerol can be used by itself to produce glucose. Most body systems can use fatty acids interchangeably with glucose for energy. Again, the brain and the nervous system, as long as the red blood cells cannot. They have to get their energy straight from glucose. They cannot use fatty acids. So here we have proteins. Proteins are needed for the formation of all body structures. Protein is a very important component, and they come from amino acids. Amino acids are the building block of proteins. And the thing with amino acids is our body has very limited storage of excess amino acids versus where we have this very large storage of excess fat or fatty acids. And the glycogen, we don't really have that for protein. Glucose is regulated by a few different hormones coming from the endocrine pancreas, gut-derived hormones, and there are counter-regulatory hormones. So for the endocrine pancreas, it is the islets of Langerhans, and they secrete hormones into the blood. The islets is actually only about 1 to 2% of the pancreas. These beta cells are what secrete insulin and amylin. So there's alpha cells that secrete glucagon, and delta cells secrete somatostatin. Then the gut-derived hormones, an increase in insulin release after nutrient intake happens. And for counter-regulatory, they help maintain blood glucose levels during periods of limited glucose intake or excessive glucose use. So this is just a slide that shows you what the islets of Langerhans looks like. So here you have the islets, and within it are the alpha cells, the beta cells, and the delta cells. Insulin is the only hormone known to have a direct effect in lowering blood glucose levels. The other hormones just have an indirect effect. And their actions are going to be to promote glucose uptake by target cells and provide for the glucose storage. Remember, that's stored as glycogen. They also prevent fat and glycogen breakdown and inhibit gluconeogenesis and increase protein synthesis. Glucagon, again, is going to be produced by the alpha cells, and they travel through the portal vein to the liver. The actions are to increase the blood glucose, that's going to be the main one, initiate glycogenolysis, right? So again, that breakdown of glycogen. When you break down glycogen, it actually raises the blood sugar in just a matter of minutes, so it's a very quick process. It also increases transport of amino acids into the liver and stimulates gluconeogenesis, right? So again, that's the conversion of amino acids into glucose. Secretion is regulated by blood glucose. So if you have a decrease in blood glucose, this is going to produce an immediate release of glucagon, and vice versa. If you have an increase in blood glucose, there is not going to be a release where there's going to be decreased release of glucagon. So the next two slides are videos. One of them is on patient education, and the second is for healthcare providers. So I want you to pay attention to the difference in each video. Right? Look at the depth of content presented and the level of presentation. Right, so which of these is more appropriate for the professional to develop a deeper understanding of the disease versus which will allow the healthcare provider to come up with a plan or be able to explain it? So just take a peek at both of these videos. They should help you in understanding this process. All right, so more specifically on diabetes or diabetes mellitus, it is a disorder of carbohydrate, protein, and fat. It results either from the lack of insulin production, the lack of response to insulin, or sometimes both. So when you see type 1 diabetes, it is the lack of insulin production. Whereas type 2 diabetes starts off as a lack of response to insulin, but as it progresses, you start to see some destruction of the pancreas, and you start to see decreased insulin production. Insulin actually wasn't discovered until 1922, so anytime before that, diabetes was actually a fatal disease. For those of you who like word breakdowns, it is derived from the Greek meaning going through, and then mellitus is derived from the Latin word for honey. There are 4 major types of diabetes. With type 1, as I mentioned, there is no insulin production, and this is because of the destruction of the beta cells in the islet of Langerhans. It only accounts for about 5 to 10% of people that have diabetes. The vast majority of diabetics are type 2. So with type 2, a person does continue to produce some insulin, but the cells are not responding to the insulin. So there's this insulin resistance that occurs. And then what happens to the body is the body sees that it isn't going in, so the compensatory mechanism is to release even more insulin. So this is where you start to see that destruction of the beta cells. right? So about 90 to 95% of people diagnosed with diabetes, it is type 2. This third type is gestational diabetes. It occurs during pregnancy, right? It's a lovely little gift that your fetus gives you. And it accounts for about 2 to 5% of people with diabetes. The good thing with this one is that it goes away after the delivery of the baby, but it does put the mom at higher risk of developing type 2 diabetes in the future. So this is deemed more of an acute condition, so you will talk about this in the 29s. We're not going to focus on this type. For the purposes of our lecture, we're going to focus on type 1 and type 2. The other type of diabetes is actually called other type. So sometimes it's because there's another disease that causes it, or basically it's just a catch-all for if they don't really understand where the diabetes is coming from, they just call it other type. Another term to think of that's not listed on here is prediabetes. So prediabetes is going to be diagnosed in people that have elevated blood glucose levels, but they're not high enough to meet the criteria for diabetes. And we'll talk about what that criteria is in a little bit. So some etiology or risk factors. Again, focusing on type 1 and type 2. So as I mentioned couple times now, type 1 is from that destruction of the beta cells within the islets of Langerhans. So you have no insulin being produced. So if there's no insulin produced, there's no control in blood glucose levels. There is a genetic link to it, and then they think some environmental factors can trigger the destruction. Environmental triggers, so things like viral infections, they found mumps, rubella, these kind of things can contribute to it. Chemical toxins, so things found in smoked or cured meats, result in an autoimmune response and they destroy the cells. The risk is 1 in 400 to 1 in 1,000 in the general population, and it increases to 1 in 20 to 1 in 50 for children who parents have diabetes. So much higher risk with familial link. So it's believed for type 2 that heredity does play a role in developing it. So again, as I mentioned, it is due to insulin resistance. The beta cells in the pancreas still produce insulin. The body is just resistant. The target doesn't uptake it. So some factors that are going to increase this are obesity, inactivity, illness, certain medications, and increasing age. They're really unclear of the exact mechanism of how this all happens, but they do know that weight loss and exercise can actually improve insulin receptor response. So I'll give you an example. My sister-in-law was actually diagnosed with diabetes, and after she did this keto diet and she's lost about 100 pounds, her blood work no longer shows that she's diabetic. Some other risk factors, somebody with, again, who had a history of gestational diabetes, someone with polycystic ovarian syndrome, or if you delivered a baby over 9 pounds, you guys have an increased risk of developing type 2 diabetes, as well as anyone with a history of hypertension, low HDL cholesterol, elevated triglycerides, metabolic syndrome. These are all things that are going to put you at risk. Right? It is more prevalent in American natives than some of the other groups, but we'll talk about that more. So there are some hormones involved in diabetes. Those are going to be your insulin, your glucagon, and somatostatin. When a person eats and the glucose levels begin to rise, insulin is secreted by the beta cells, and this is going to facilitate movement of glucose across the cell membrane to provide energy to the cells and reduce the amount of circulating blood glucose. It also prevents glycogen breakdown in the liver and fat breakdown. Circulating insulin is going to bind to the receptor sites, and the result of this is that the cells receive glucose for energy, and again, circulating glucose decreases. So upon eating, insulin rises within about 30 to 60 minutes, and then it returns back to baseline within 2 to 3 hours. So for glucagon, when blood sugar levels are low, glucagon is released by the alpha cells, and this stimulates the breakdown of glycogen in the liver, resulting in the formation of carbohydrates in the liver and the breakdown of lipids in the liver and fat cells. So this whole process is called gluconeogenesis, so again, making new glucose from fat and protein, and glycogenolysis, breaking down glycogen in the liver. Glucagon prevents blood glucose levels from dropping, so in most people, glucagon is released when the glucose level falls below 70. This is, again, like a compensatory mechanism the body has. So this is usually seen during times of fasting and in between meals. The last hormone is somatostatin. It is released by the delta cells in the islet. It is a neurotransmitter, and it's believed to inhibit the production of glucagon and insulin to aid in the control of glucose levels. You can hear my cat meowing in the background. Anyway, so here we're going to talk about diagnosing diabetes. Screening is recommended in children and adolescents younger than 18 when they're overweight or obese, and if they have more than one risk factor of diabetes, as well as adults. So testing is completed on those with a first-degree relative who has diabetes, if you're a high-risk ethnicity, if you have a history of cardiovascular disease, hypertension, low HDL or elevated triglycerides, women with polycystic ovarian syndrome, anyone who is physically inactive or obese or has a history of gestational diabetes. All of these people are going to or should be having their blood glucose levels checked routinely. There are several different ways to diagnose diabetes. One of them is going to be looking at the fasting glucose. Right? So fasting glucose measures plasma glucose level after food has been withheld for at least 8 hours. So you want to make sure when you're taking a fasting glucose that they haven't eaten within, as I said, the last 8 hours. So normal range, so somebody who does not have diabetes, is going to be below 100. Once you start to see 100 to 125, that's that impaired or pre-diabetes range. And if it is at or above 126, that is in the diabetic range. But just keep in mind, if there's only one time elevation, it's not enough to diagnose diabetes. Right? They do need to obtain a second test to determine it. So if the second test shows that it's higher than 126 fasting as well, then the diagnosis of diabetes will be made. One of the other tests is the oral glucose tolerance test. This measures the body's ability to remove glucose from the blood within 2 hours of consuming 75 grams of glucose and 300 mLs of water. This is a pretty common test done for women when they're pregnant and looking at gestational diabetes. Basically what it is they give you this overly sweet drink, right? It's got the 75 grams of glucose. To me, I had an orange one and it tasted like if it was flat Sunkist, right? So you drink this and then they check the blood in about 2 hours after consuming it. And then in normal range is going to be less than 140. Impaired range is 140 to 190. Again, when you think impaired range, it's pre-diabetes. And then a positive diagnosis of diabetes is if it is at or above 200. The last test that they do to diagnose diabetes is the glycosylated hemoglobin, easier known as hemoglobin A1C. And this one is going to reflect an average blood glucose level over a 2 to 3 month period of time. So with this one, people can't cheat. Right? So my older daughter is a type 2 diabetic, and anytime she goes to her doctor, she really makes sure that she is eating healthy the last couple days before, and she'll check her blood sugars and there'll be good results. But I always tell her it's kind of pointless because once they do the A1C, they're going to see how it is for that 2 to 3 month period of time. The doctor is going to know that these last couple results of blood sugar were just you preparing for the doctor and not really the full picture of what your diabetes management looks like. So with that said, the normal range for an A1C is 3.9 to 5.6%. Prediabetes is 5.7 to 6.4%, and diabetes is anything above or at 6.5%. So here's the list of manifestations of diabetes. With type 1, you usually see a very rapid onset of these signs and symptoms, whereas type 2 develops more insidiously or more slowly. So the first signs and symptoms are called the 3 polys or the 3 Ps. Right? So you've got polyuria, increased urination, polydipsia, increased thirst, and polyphagia, increased hunger. With the increased hunger, you see that a lot more in type 1 than you will see with type 2. Okay. So this is occurring because elevated blood glucose levels actually cause cellular dehydration. And it's because of that large amount of water lost in the urine. So you've got more urine, and then causing your cells to be dehydrated, you're going to have increased thirst. You'll also see hyperglycemia, obviously, right? So high blood glucose levels. Glycosuria, the glucose going into the urine, right? It's not supposed to spill into the urine. Our urine is supposed to have 0 glucose in it. With type 1, you see a lot of weight loss. And then you can also see blurred vision, paresthesias, and skin infections, along with yeast infections. Some complications of diabetes, some terms to be aware of. Again, hyperglycemia, high elevated blood glucose levels. This is a problem because if it is untreated and it goes on long enough, for type 1 diabetics, it can result in diabetic ketoacidosis. And type 2, it can result in hyperosmolar hyperglycemic state. And we'll talk a little bit more about that. Another term is the dawn phenomenon. And with this one, you have a rise in glucose between 5 and 9 a.m. That is not because of hypoglycemia. They really don't know why it happens, but they think it has to do with nighttime increases in growth hormone. Right, so that's a good way to differentiate dawn versus Somogy. Dawn, again, is not because of hypoglycemia. Whereas your Somogy syndrome occurs when there is hypoglycemia at night. So again, your body likes to make sure that is balanced, so it freaks out and it compensates by increasing blood glucose levels. So this leads to rebound hyperglycemia. Right? So usually they test this by waking someone up, right? They wake them up in the middle of the night and they look and they see if they did go hypoglycemic, and then they would expect to see hyperglycemia when they wake up in the morning. Some more complications. You can have microvascular complications, so the small vessels. And this is going to be because of the change in the basement membrane of the smaller vessels. And this can lead to things like diabetic retinopathy and diabetic nephropathy. Can't speak. Okay. Macrovascular large vessels occur because of atherosclerotic lesions. So things like coronary artery disease, hypertension, stroke, and peripheral vascular disease. People who are diabetic are also at risk for mood alterations. Any chronic disease is going to increase your risk of depression. Plus, you've got this complex self-care that needs to happen. chronic strain and stress. There's a lot of financial burden, emotional stress, social distress. So all of these can cause those mood alterations. And then another complication is going to be periodontal disease. So a couple acute complications of impaired glucose regulation. The first one being, as I mentioned before, diabetic ketoacidosis, or DKA. It is hyperglycemia, ketosis, and medical acidosis. It is life-threatening and primarily seen with type 1 diabetes. This is actually what a lot of the time leads to someone being diagnosed with diabetes, because you don't see a lot of symptoms, if you really think about it, until the blood sugars becomes really out of whack. So for the definitive diagnosis, it's going to be a blood glucose level greater than 250. They're going to have low serum bicarb, low atrial pH, and a positive urine and serum for ketones. Right, so basically what happens is the hyperglycemia is going to lead to dehydration. This is going to lead to a loss of electrolytes. Right, with the ketosis, when the body doesn't have enough insulin, it's going to lead to the rapid breakdown of energy stores from the muscle and fat deposits. And the liver is going to convert amino acids to glucose and fatty acids to ketones. The metabolic acidosis is going to be caused by the excess keto acids, and these keto acids need bicarb ions. So if they're taking the bicarb, you're going to have decreased serum bicarb, thus acidosis. All right, so some symptoms. Your 3 Ps: polyuria, polydipsia, polyphagia, nausea, vomiting, fatigue, a stupor that can eventually progress to a coma, fruity smelling breath, and that's from the ketones. It smells like rotting fruit or very overripened fruit. And then hypotension and tachycardia from the dehydration that occurs. So the way they are going to treat this is improve that circulatory volume and tissue perfusion, and this is done by fluid replacement, decrease blood glucose with insulin, and correct the acidosis and electrolyte imbalances, so replacing electrolytes, giving bicarb, and these kind of things. So the second acute complication is the hyperglycemic hyperosmolar state, or HHS. With this one, water is pulled out of body cells, including the brain cells, so you're going to see dehydration. It is a lot more common in type 2 diabetes, and it can be fatal. Right, so they're going to treat it basically the same way they treat ketoacidosis. They want to fix the fluid and electrolyte imbalances and treat the hyperglycemia. One of the key differences is looking at the hyperglycemia. So with your ketoacidosis, you don't see it that elevated. Whereas with your HHS, blood glucose levels are over 600. So that is, again, going to result in that hyperosmolarity, or having that water pulled out, and then the dehydration. Another way to distinguish is there's no ketoacidosis here. It's not a problem of insulin. You're going to see polyuria, polydipsia, and then some CNS signs. So they're going to have the Babinski reflex, hemiparesis, aphasia, hyperthermia, hallucination, seizure, and potentially coma. This one comes with a lot higher risk of mortality than ketoacidosis does. And if you look at the CNS signs, they kind of can mimic a stroke. And this is the same even with just hypoglycemia as well. And we'll talk more about that. But anytime you start to see some neuro symptoms, the first thing you also always want to do is grab a blood sugar, because that might just be the problem. All right, so some acute complications related to hypoglycemia. Hypoglycemia usually occurs when someone has more insulin than the food they consume. So if they take their insulin shot but then they don't eat, or if they take too much insulin. Signs and symptoms, as I just mentioned, that altered cerebral function. And I'm telling you, I've seen countless times where they have called a stroke code, and when we go and we check the blood sugar is like 40. It's like, well, they're not having a stroke. They are just simply hypoglycemic, and you need to treat it, and then they come out of it. So it can activate the autonomic nervous system, so they start to see hunger, anxiety, tachycardia, sweating, and cool and clammy skin. The treatment, they call it the rule of 15. So 15 grams of a concentrated carbohydrate source with glucose working the best. So they do sell glucose tablets, otherwise they tell people to carry lifesavers or orange juice or something like that. This is going to be repeated every 15 minutes. That's why they call it the rule of 15. Every 15 minutes up to 3 doses. So let's say you check your patient's blood glucose. It is 50, right? You give them that 50 grams of glucose. You recheck it in 15 minutes, and now it's 55. You give them another 15 grams, check it in 15 minutes, and it can be repeated one more time. Once you get it up, what you want to make sure you do is give a complex carb. So they say like peanut butter and crackers or peanut butter and milk, something like that, because you want to control the blood glucose level. You don't want it to drop again. Let's say they're unconscious though. So they're unconscious, you check, their blood glucose is 40. They're not going to be able to swallow those 15 grams of your glucose. So you can give glucagon. It's available either IM or sub-Q. Or you can actually give glucose, and that's going to come in 20 to 50 mLs of a 50% solution, and you give that IV. You need to give it slowly IV, but I always tell people not to worry about that because it is such a thick, it's kind of like pushing maple syrup into an IV. It's so thick, it takes forever to push it through anyway. So a quick question for you. The nurse is caring for a client that has polycystic ovarian syndrome and delivered a baby that was 9 pounds, 14 ounces. Ouch. What type of diabetes is the woman at risk for? Is it type 1, type 2, gestational, or latent autoimmune diabetes? And the answer is type 2. So briefly, here's how we treat diabetes. We will talk about it a lot more in chronic lecture. We're basically going to have the goal of maintaining normal blood glucose, right? So you want to maintain a hemoglobin A1C below 7%. Right, so just keep in mind that is still higher than the average or normal A1C, but you have to be realistic. They have diabetes. We want it below 7. We want preprandial or pre-meal glucose level of 80 to 130. And you want the peak postprandial, so peak after meal, to be less than 180. Right? And the goals might be a little more strict or a little more lenient, depending on the person and the provider. So it is a little bit of an individualized plan. So with treatment, you want to think of management as a 3-legged stool, right? You've got the picture here of one. You want to think of it as diet, exercise, and medications. You want a well-balanced diet with a controlled amount of carbohydrates. You want the simple carbs versus complex carbs. Wait, scratch that. I got that backwards. You want complex carbs, not the simple. Right, so you want to limit sugars. Your sugars are your simple carbs. You want to make sure you have a lot of fiber because it's non-digestible carbs, and then you want to increase your starches. Your starches are your complex carbs. Okay? About 1/4 of your plate should include starchy foods. You want to maintain a regular exercise program, and then you want to monitor blood sugar, especially before meals and before exercise, so you can get an idea of how your body is affected by exercise. And then drug therapy may be needed. And that brings us to our last slide. We are again going to cover it a little bit more in chronic and way more in pharmacology. And it's going to include your insulin and your hypoglycemics. All right, so if you remember what is causing type 1, they've got a lack of insulin. So type 1 diabetics are always going to be treated with insulin, never with oral pills. And so always insulin. Whereas your type 2 diabetics usually are started on your oral hypoglycemic agents, so things like metformin. And they may also have insulin added if they're having trouble controlling it with just the pills alone. So these oral hypoglycemics, they're going to work in a couple different ways. So they're either going to stimulate or increase insulin secretion. They're going to prevent breakdown of glycogen in the liver. They're going to increase glucose uptake by the cells, so they're going to reduce insulin resistance. And they're going to block absorption of carbohydrates. All right, and that concludes our lecture on endocrine and metabolism for patho. Just look out for the chronic lecture to come your way.